the Jacobs Institute, a nonprofit medical device innovation center in Buffalo, New York. The Jacobs Institute is proud to welcome you to the second webinar in our series, An Expedited Pathway to TAVR, Protecting the Patient Providers During the COVID Pandemic. This webinar series has been generously funded with an education grant from Edwards Lifesciences. So all 4 webinars in the series will be moderated by Dr. Vijay Iyer, who will be joining us as soon as he finishes a case, and each will highlight the best practices that each center, all participants in the Edwards Benchmark program, have used and are using to address the challenges posed by the COVID-19 pandemic. Before introducing Dr. Iyer and the panelists, I wanted to mention that you can chat in questions throughout the webinar using the chat feature at the bottom of your screen, and we highly encourage questions. We'd also be grateful if you would fill out the survey that's going to pop up with a link at the end of the webinar, because that helps us improve webinars moving forward. So on to the introductions. Dr. Iyer is our moderator. He's the Director of Structural Heart Interventions at Expedited Health in Buffalo, New York. He's an interventional cardiologist specializing in structural heart interventions. He directs the complex valve clinic at the Buffalo General Hospital and operates out of the Gates Vascular Institute, which is a hospital within the Expedited Health system. His research interests are in new devices for aortic and mitral valve replacement, novel therapeutics in the form of stem cells, and newer therapies for acute coronary syndromes. Dr. Iyer serves as the local PI for a number of multi-center clinical trials. So our panelists include Dr. Thomas Daly, Director of the Valvular Heart Disease and Complex PCI Programs at CentraCare Health, Heart and Vascular Center at St. Cloud Hospital. Dr. Daly attended medical school, residency, and cardiology fellowship at the University of Minnesota and completed his interventional structural heart training at Scripps Clinic in La Jolla, California. He has a special interest in subclavian and axillary access for TAVR and mechanical support for shock and high-risk PCI. Then we've got Phil Martin, who's the Executive Director for CentraCare Health, Heart and Vascular Center. Phil is a visionary leader with more than 20 years of experience in strategic planning, new services initiatives, financial analysis, and fiscal management within a healthcare environment. For the last 6 years, Phil has been the Executive Director of the Heart and Vascular Center at CentraCare Health. Prior to that, he spent many years as Director of inpatient and outpatient, interventional, and invasive cardiac care at St. Cloud Hospital. Phil has a Bachelor of Science in Nursing degree from the University of Phoenix, Colorado, and a Master's in Business Administration from the College of St. Scholastica. Then we have Sarah Denzel, who's the Valve Clinic Coordinator, CentraCare Health, Heart and Vascular Center. Sarah started in her current role in 2016 after graduating from the University of North Dakota with her Master's in Nursing. Prior to her role in the Valve Clinic, she worked as a nurse on a medical progressive unit for 3 years, but knew her passion was in cardiology. Since starting in her current role, she has been able to witness and be a stakeholder in the continued advancements in patient care and programmatic changes that have taken place at CentraCare. So thanks everybody for joining today. And maybe while we wait for Dr. Iyer to join, we can kick it off with you, Phil, talking a little bit about some of the changes that you've had to make and are continuing to make in the face of this COVID-19 pandemic.
Great, thanks, Pam. I'm gonna go ahead and share my screen. We see that okay?
Yep, we see it well.
Okay. So thank you all for attending today. We appreciate the opportunity to bring our program forward as amidst this COVID second surge pandemic. The first slide that I'd like to share with you is kind of a slide within a slide. One shows our service area and then also where we're located within the state of Minnesota. So we truly are located in central Minnesota. This is the Stearns County where St. Cloud Hospital and CentraCare Health System exist. And then this is a representation actually of our 14 county service area. The 14 county service area serves a population of about 800,000 patients. Our nearest competition as it relates to advanced cardiac care is probably Minneapolis at about 90 miles. And then as you go farther west is Fargo, and then out to the east and northeast is Duluth. So we really do have a very good catchment area for advanced programs like TAVR. So kind of starting back before, at the beginning with our TAVR program and the pre-benchmark program in 2019, I'll just go back that far, even though it started prior to that. You know, we had TAVR Tuesdays, not unlike a lot of programs. We'd do 3 to 4 cases per day. We performed all those cases in the OR with anesthesia support. Post-anesthesia, the patients would go to our cardiac intensive care unit, and a typical length of stay for that patient population was about 2+ days. Moving on to TAVR 2020 and post-benchmark program. Although TAVR Tuesday was continued, we did move some of the cases up into the cardiac cath lab and really alternated weeks between OR and the cath lab. Even though we did move cases into the cath lab, the anesthesia group continued to support that patient population primarily with general anesthesia. The one move that we did make is that we moved from recovering that patient population in our cardiac intensive care unit and bringing them directly to our cardiovascular thoracic unit using a CICU RN. So what that ultimately did is it reduced the need to transfer from one unit to the next unit, even though those 2 units are adjacent to each other. So that did save some nursing time along the way, and it actually made our nurses more expert in the care of that patient population. Also with this is that our ART lines continued, so despite being in a CVTU status room, we did continue to monitor patients with ART lines. We did move to next day discharge and actually had success in doing that at greater than 85%. Then COVID hit, as you all well know, and that was a significant impact to how we managed this patient population. And for us, our first surge really started in March and ran through May. So at that time, our governor was involved. It was a shutdown on elective procedures. So really the TAVR program to a certain extent was suspended. On average, we were limited to 2 patients per week due to OR availability and anesthesia availability. We had to triage all patients with critical AS or severe symptoms to prioritize which patients actually got to have a TAVR. And when Dr. Dolly takes over the slide presentation, he'll further get into that conversation. We also had many patients that were too scared to come into the hospital and decided to not move forward with their TAVR, ultimately resulting in worsening symptoms and then creating a more critical nature for that patient once they did make the decision to come into the hospital for that procedure. And then we ended up with a significant backlog because number 1, we were shutting down electives. Number 2, we had patients that were really not wanting to come into the hospital. That backlog did develop. Once we came out of that first surge, we continued to look for opportunities on how we could improve upon the program. And through the help of Dr. Dolly and Sarah Dizelle, anesthesia, and our cardiovascular thoracic unit, and our cardiac cath lab, we really transitioned into a point where we were primarily doing cath lab procedures, unless there was an alternate access TAVR, of which we would then continue to do those in the OR. We did kind of back off on our general anesthesia at this point too, and went more to a nurse monitored sedation, which created a lot more flexibility and a lot better throughput versus going through the OR. It was easy for us to, at that point, to increase the number of TAVRs we did in a day just by utilizing the cath lab versus the OR. All recoveries then returned to CVTU, and we did stop utilizing our CICU staff for the recovery of those patients and actually put them into an actual CVTU bed. And we do not have ART line capabilities in there. So that was a change that was negotiated with anesthesia in order to make that switch occur. And then really as a standard, the patient would recover in CVTU one day and then be discharged the next day. Unfortunately, we're now into our second surge. The second surge for us started really at the beginning of this month and continues to go on. I can tell you that we're a 495 bed hospital. We average a census that's probably around 400. Right now, we're running 25 to 30% of our patients are COVID patients. In our hospital today, roughly 134 positive patients, 107 on our medical units, 27 in our critical areas. We also made a change where The second floor in our hospital represents our cardiac intensive care unit, as well as our cardiovascular thoracic unit. The cardiovascular thoracic unit, where our TAVR patients were going, is a 20-bed unit, but because of the influx of the COVID patients, the decision was made to totally take over that 20-bed cardiovascular thoracic unit. So now we've transitioned not 20 beds, but 8 beds into our cardiac procedure recovery unit, which is an outpatient recovery unit. And that 8 beds is used to not manage just TAVRs, but it also manages open hearts, MitraClips, Watchmans, patients coming out of our outpatient unit and having PCI, patients coming out of our outpatient units having EP intervention, as well as devices. So we put a severe limitation on the number of patients we can actually do on any given day, given this 8-bed limit. So the result is that we've gone from TAVR Tuesday, which used to be 4 TAVRs in a day, to trying to spread those out to 1 TAVR per day, because that's more easily managed for us on a day-to-day basis, given the limitations of the beds that we have. So we're really migrating to a Monday through Friday TAVR program, of which the vast majority, if not all, are being done through the cath lab just because of a throughput situation, recovered in our cardiovascular thoracic unit because they're only receiving conscious sedation, no outlying, with a very quick discharge the next day. The challenges, of course, that are associated with that is with the need for both, an interventional cardiologist like Dr. Dolly and also a cardiovascular surgeon to be present. We do have a coordination challenge associated with that, but to the credit of both of those groups, that is actually working extremely well. As we face this bed challenge, I have submitted to the Minnesota Department of Health a request to transition some of these outpatient beds to inpatient beds to try to give us more flexibility. And successfully so, the Minnesota Department of Health has actually responded typically within 24 hours to allow us to expand beds. Unfortunately, we're working in a 24-bed unit where our outpatients go and where these inpatients will go. So we're going to have somewhat of a balancing act between the demand of outpatients and the ins and outs of those, along with our inpatients, those being our open hearts and TAVRs, MitraClips, Watchmans, PCIs, EP ablations, and devices, and trying to somehow have patients discharged as we bring other patients in and totally maximize the utilization of those 24 beds. So at that point, I'll pause and I'll hand this over to Dr. Dolly to continue on with the conversation, unless anybody has any particular questions for me at this time.
I don't see any questions right now. Thank you, Phil.
Well, thanks, Phil. Just want to welcome everyone to this series and also just encourage people to use the chat function. If you have any questions for us, please feel free to interrupt us. This is meant to be a interactive experience where we can talk live and pause rather than waiting till the end of the time. I also just want to take a moment to thank Phil Martin for his incredible work from an administrative side. If one thing that 2020 has taught us is that just when you think you have things planned and laid out, COVID throws more surges or more hurdles for you to face. And all of this that we're doing right now, we certainly couldn't do without well-organized leadership from our hospital administration and everyone on the team, including Sarah, who is the cornerstone of our team and will follow me and talk about a lot of the changes that we've really had to do on the fly. And in fact, even our presentation we're doing today, we had this done about a week in advance, but we had to, rewrite and rethink several of the things that we're facing even as late as yesterday. And that's how live and fluid this all is. What I wanted to focus on is really the notion of elective TAVR. And when is TAVR truly not urgent? With COVID, we're basically, forced to try to triage, and especially with our limited beds, say, well, we can only do TAVR on urgent patients. And the question that I'm posing for everyone, and I'd open this up for discussion, is, when do you say TAVR is truly not urgent? Is it based whether or not they have presence or absence of symptoms? Is it whether or not they have low EF, or is it the degree of AS they have? Is if they only have severe AS or lower gradients instead of critical, would that be considered not urgent? Do you look at other factors like LVH, lack of LVH, or are there other factors as well? And then the other big question we had to ask ourselves is, well, how long can these patients wait? A lot of these patients have to wait because of COVID and our limitations. But a lot of these patients want to wait themselves because they're afraid of COVID and they don't want to come into the hospital, rightfully so, or they don't have the same social network for family and loved ones to help care for them or bring them to the hospital due to isolation, even from their own family members, and also helping with the recovery once they go back home. So these are all real issues that they're facing. Phil, can you go to the next slide? So on that notion, just to kind of recap what Phil had as well, initially in March, May, we triaged all patients with critical AS or severe symptoms to be urgent. Sarah will talk about that a little bit more in an initial kind of letter classification system that we developed to try to help manage and keep track of these patients. During that time, we had 3 patients with severe AS that were not felt to be urgent that unfortunately did die suddenly while awaiting their workup or scheduling for TAVR. When we moved to COVID kind of June to September, when our numbers had stabilized and we had a flattening of the curve, the elective procedures resumed. However, we had a large backlog of TAVR patients that we had to get through and determine what order to get those through. Now, when we're in our second surge, now through October and November, we're even having difficulty getting our urgent patients scheduled due to the limited rooms and having to work with creative workarounds, as Phil mentioned, and Sarah will go into a little bit further. And just to give you an idea of how that affects patient, we did have one additional recent death of an urgent patient awaiting scheduling. And then the other important thing to remember is that a lot of these patients are at high risk, even for COVID. And we actually had 2 patients in the last month awaiting TAVR subsequently died from COVID. One of them was scheduled for TAVR but became COVID positive, so we had to postpone their procedure, and they subsequently were admitted to the hospital and succumbed to COVID. So it's important to know not only are these sick patients, but they're also more at risk for complications and even death from COVID as well. Next slide. In terms of how long can we wait, I went back and pulled the original slide from the partner study when we looked at doing TAVR with SAPIEN compared to standard therapy in non-operable patients. And I thought this was a good example to remind ourselves, well, how long can we wait? If you remember in this sick group of cohort patients, non-operable, these were non-operoable severe AS patients with symptoms. At about 12 months, 50% of these patients who underwent standard therapy, there's a 50% higher mortality rate at 12 months. And so it's important to remember that in days of TAVR that we're used to getting these patients through, there is a significant increased risk of mortality in patients with severe AS who don't undergo TAVR or are waiting to undergo. Next slide. One of the things that we've often talked about is we have, obviously we have all the challenges from COVID. One of the things that hopefully this webinar will help with is really focusing on what are some of the green shoots or what are the positives that have come out of COVID. It's really hard to focus on that when there are a lot of negatives and challenges and hurdles that we're having. But if you think about these positives or what I would call green shoots or new growth, what has that led to change for us? And thinking about this in terms of our program, it really forced us to implement change much quicker. We're used to discussing change, coming up with a plan, implementing that plan. But in the setting of COVID, we really had to learn how to implement and come up with change almost on a day-to-day basis in a much quicker fashion. One of the other green shoots I would say from COVID is that previously perceived barriers to change were suddenly now removed. There really isn't time for preconceived notions and resistance and barriers. We really have to kind of address them head on and then move forward. Also in that terms, intradepartmental barriers, I've also noticed, also seem to decrease as common values and goals really begin to develop and merge, where we're all in the process together trying to care for our patients during the pandemic. And then the other thing I noticed is we saw more creative and efficient utilizations of resources, which are now scarce. Phil even talked about that, how transitioning some of our outpatient beds to CVTU and how that can affect that.
I think there was something in the chat.
Yeah, I was just going to say. It says, in regards to using a direct admit to CVTU, do you require the use of a PACU, or because you're using conscious sedation, you don't require anesthesia recovery? If the latter, what about frequent site checks required that aren't necessarily the norm for med-surg staff?
Muted.
I think that's a great question. I think, Sarah, I'll put that question to you, as you're in charge of more of that pathway, and could let them know what we do with that.
Yeah, so when we transitioned to CVTU, because they were a conscious sedation, almost like a angiogram or PCI, actually sometimes often less sedation than a PCI, we could easily transition them to that type of unit without any concern for needing a PACU bed or an ICU nurse, trained nurse, etc. And that also then allowed us to be able to move to kind of an RN sedation, because we didn't need anesthesia to transfer either, help with recovery. And so in doing that, really still site checks are quite frequent. You still have a large bore access, so anesthesia sedation type doesn't really tend to affect that. Our site checks stayed the same as the large bore access. We did get patients up sooner though, because they didn't tend to have as much hemodynamic change and need for 6-hour bed rest. So now it was like more of a 4-hour bed rest, and still no concern with increased bleeding risk or complication there. We watched that closely. So, they're kind of this mix between, we don't really need ICU, PACU, the anesthesiologist in that typical scenario, this type of patient, but they're not really still like your med-surg patient where, you do their neuros in 4 hours. We still do a lot of site checks, a lot of neuro checks in the first hour, gradually transition that to the second and third hour, and then they're up walking at hour 4, and then it kind of is a unit routine for vitals and neuro checks and site checks.
I think that's a great example of our last point there that I was talking about, with more creative and efficient utilization of resources and just how to do that. So that was perfect timing for that question.
Yeah.
I think
follow-up question about nursing ratios there.
Phil, do you want to add to that first?
Yeah, I think one of the nice things about the setup that we have is that our cardiac cath lab is somewhat adjacent to our cardiovascular thoracic unit, which is the unit that we use to put these patients in. If we were to continue the use of PACU, that's located 3 floors below us. So it's really transferring a patient out of the cath lab, down to the PACU for recovery, back up to the floor that they originated on, and then into their bed. So we can save a lot of time going cath lab directly to CVTU, and that's why it's easier for us to have really great throughput and do 4 cases, by the middle of the afternoon.
Mm-hmm. And then the follow-up question to affecting nursing ratio, I think is a great question, because we certainly started in the beginning when we had transitioned to some of the CVTU stuff. It wasn't directly during the pandemic, so we had kind of time to ensure some of that safety protocol type stuff. So in the beginning, we did increase kind of that nursing, or I guess decrease that nursing ratio just in the first couple of weeks, to having be like 1 nurse for every 2 patients. And now it's your kind of typical ratio for that type of like telemetry CVTU unit. So they can have up to 3 to 4 patients, even with bringing back a new TAVR. Our charge nurses do a very excellent job, however, at figuring out kind of what would be best suited based on the time of the procedure and the type of patients that the other nurse has when they're taking back a new TAVR. So a lot goes into nurse education and having that charge nurse really understanding the complexity right in the beginning of the couple hours and how busy that nurse is going to be.
Okay. Phil, do you have anything to add to that, or?
I don't think so. I think Sarah nailed it on the nurse to patient ratio. So she's exactly right what she stated.
Okay. Why don't we go to the next slide then?
Oops.
What we thought we'd do is really discuss how COVID has changed our program, and I kind of broke it up in these 4 categories. You know, what was the differences we made in patient referral and initial evaluation? Sarah's going to talk about that. I'm going to focus a little bit on procedural changes, and then we'll kind of follow up with inpatient post-procedure care as well as patient follow-up, which Sarah will focus on as well. So if we can go to the next slide. And one more. So in terms of procedural changes, you know, early on, March through October, every TAVR patient, we would have routine COVID testing prior to undergoing their TAVR. Recently now with the second surge and the changes we had, we looked at our resources and often difficulty getting these patients in for testing and getting testing results back in time for the procedure and trying to time for that. We decided to make the change to stop routine TAVR COVID testing in TAVR patients prior to the TAVR, unless they were undergoing general anesthesia. And this followed on with guidelines for our other procedures, basically saying, you know, these TAVR patients aren't being intubated. They're not undergoing a procedure that has a high risk of aerosolization and airborne, such as a transesophageal echocardiogram or intubation, and really treating them like our coronary angiograms, which we do not routinely TAVR test, COVID test prior to their procedure, and make that switch, which we did in end of October. Also for the pre-ops, instead of bringing them into the hospital, which we would do usually the day before, we transitioned those to telemedicine, over the phone, and admit earlier for lab work the same day the procedure to try to limit that. I'll pause there to see if anyone has any questions, or to see what other programs are doing in terms, are you testing your TAVR patients for COVID routinely, or have you switched to a similar model? Vijay, what are you guys doing there?
So Tom, you know, we were mandated by the hospital to test everybody. In fact, by New York State mandate, anybody having a procedure in the hospital, they actually use the term surgeries or procedures had to be tested for COVID, and that continues to this day. In fact, we are still testing everybody. We have had very few people, at least as of last week, who have actually tested positive in this process. But having said that, in the last 2 weeks, as our rates have gone up, we have actually canceled a few procedures because people have tested positive. So even for those people who we tested and were negative, we treated everybody as though they were COVID positive. So they were in the hospital, they were masked the whole time. If they needed intubation for any reason, it was treated like, like a COVID positive patient. So anesthesia was in full PPE to intubate them. So that was, but that was a state mandate. I'm not necessarily sure that, you know, we've done. The only thing I will say is that for those patients, and we know the data that for those patients who do have an active COVID infection and have any surgery or procedure, their mortality is much higher than anybody else. So we had one mortality in our TAVR program, which is an inpatient TAVR that we did, who turned positive after the TAVR, 48 hours after, and did not have a good outcome. This was somebody who was on dialysis as well. So that's been our experience. So I think some of that is probably state by state and hospital mandates.
Sarah, did you have anything you wanted to add to that at all? Okay.
I think the challenge for us in this situation is the type of testing that's made available to us, especially for elective procedures. You know, we have a Mayo test, we have a Panther test, we have a rapid test. For those patients that are coming in as an elective procedure, that's a Mayo test, and the results don't come back to us for what could be 5 days. You know, given the exposure rate in the community today, we're not sure there's value in doing that Mayo test because of what could possibly be exposed to even after they have the test and prior to coming in for the procedure.
And I completely agree. I think we, in the last 4 weeks, have had more access to the rapid test. And I think that has made a big difference to what we have been able to do. But as of today, our county has, or actually parts of our county have gone into what they call an orange state. So an orange state means a higher infectivity rate in the testing. So that changes quite a bit for us. So we're kind of going back to where we were in February and March in terms of our procedures and things like that. But you're right. I think a 5-day test is meaningless in the current, the current rates of infectivity. But the rapid test, if it's available, I think really does help in terms of getting people on board, and you can test them in the morning off and then keep going. It does create some unique problems though. I mean, and we bring patients in. We had a couple of patients brought in for elective angiograms, or what we thought was urgent angiograms. They had a tested positive, and now you're in a unit where, where you're not supposed to have COVID positive patients. So it creates a layer of complexity. So I don't know that there's any easy solutions here as the rates go up.
Mm-hmm. I think that's a great point. Phil, if you want to go to the next slide. The other thing, just to discuss some of the procedural changes we went through, is we rapidly implemented a cath lab transition plan. Now, we already had this in place as we're going through a benchmark program with Edwards just to improve our efficiency. But really, COVID helped, or COVID caused us to have to implement this change much more rapidly than we initially planned. And we moved to a cath lab transition plan. And what we did is we immediately put all our TAVRs in the cath lab instead of the hybrid OR, with complex and high-risk TAVRs still being performed in the hybrid OR if available. And then immediately this allowed for additional TAVR days, which we did throughout the summer to try to get back through our backlog. And then it also allowed the ability to offer immediate TAVR to inpatients admitted with AS symptoms and decompensated heart failure, rather than our routine would, pre-COVID would normally be to stabilize these patients and continue their workup as an outpatient as long as they improved. But now we've moved to a much quicker, if they're here in the hospital, they're already here, they've already had their screening and testing for COVID, and they have decompensated heart failure. If we can optimize them to rapidly work them up and perform the TAVR prior to discharge. I know, Vijay, you guys are a much larger program. Have you seen any of those kind of similar things? Are you guys trying to do more inpatient TAVRs when they are there, or are you sending them home, or what is your guys' strategy? And we said this in the last webinar too, which is we sort of categorized 2 categories of patients that we did inpatient. Anybody who showed up with syncope as an inpatient, we did them as an inpatient. And anybody with advanced heart failure that we felt was not a good candidate to go home, we did. But in that peak between March, April, in that time frame, patients were kind of avoiding coming into the hospital. So the ones who did end up in the hospital were pretty sick. We had to sort of do something with them. We didn't really have the option of sending them home. But since then, we have tried not to do a lot of inpatient TAVRs and try to get people home and bring them back if possible. But again, if they showed up as syncope or class 4 heart failure, then we ended up doing them as inpatients. Tom, the other question I had is, in your heart team, did you see patients who may have chosen to have surgery under normal circumstances, but prefer to have a TAVR simply because of the circumstances around admissions and not wanting to be intubated or opened up? We did. We've seen that phenomenon not only with TAVR, but we've also seen that with high-risk PCI, multi-vessel PCI as well. It's probably been even more dramatic with that. Even from our surgeon side, patients that, are suitable for CABG. Normally we would do CABG, but we were shunting oftentimes to multi-vessel PCI if anatomy was appropriate, to try to help expedite getting them out of the hospital.
I would add to that, Tom, too, the lack of available critical care beds, intensive care beds, or cardiovascular intensive care beds has forced the interventional cardiologists and the cardiovascular surgeons to really look at patients and see if a complex intervention is an option, whether that's Impella supported or not, versus open heart surgery, just because we're limited on our ability to place an open heart patient in an intensive care bed postoperatively.
And our surgeons kind of did this, talked about the same thing even with TAVR. If they were suitable for both, felt to be, can't really hold off, there'd be a lot of risk involved in that. And we knew we could do a TAVR, probably next day discharge with minimal potential of having complication coming back into the hospital, et cetera. We really just kind of worked as a team to say, what is the best thing for that patient right now? And talk to the patient openly about that. And we did have a lot of people that went TAVR versus surgery for that reason.
Did you see that same phenomenon there in New York?
To some extent, yes. For a while, our surgeons were not allowed to operate at all because unless it was emergent, because there was, many of the ORs were being utilized as possible beds for COVID positive patients, especially with lack of ventilators and things like that. So there was a brief period of 2 to 4 weeks where literally no surgery other than emergent surgery was being performed. So a lot of those patients did choose to have TAVR. Some patients, I will say, and chose to have nothing at all. They chose to have nothing done and wait. And that, for some of them, was not the right choice because they ended up in trouble. And for some, they waited to have surgery and had their surgeries in the summer. But it was a mixed picture. We saw all pictures at this point.
Mm-hmm.
You can go to the next slide, Bill. In terms of monitoring during the procedure, again, this was something we had already been in the works, was eliminating all radial art lines, which was previously standard on most patients. With our transitions in COVID, we implemented that change much more rapidly and with the support of anesthesia, given their limited resources as well. We also had an increased usage of nurse-only sedation with transition to the cath lab. This helped free up our anesthesia resources, which were quite limited at this time as well. And then pre-COVID, we already had a very high rate of conscious sedation, which was greater than 90%. But then, with COVID, we even moved, that number I think is even higher. It's extremely rare not to do conscious sedation. And in fact, many of our patients, we've now transitioned to no sedation and doing local anesthetic as well. And with this, I think it's just helped these patients. We have less hemodynamic instability. It's definitely coincided with our decreased ICU need and faster recovery, as well as faster discharge in these patients as well. Next slide. And I think from here, I'll pass this over to Sarah, again, who's the heart of our program, to really talk about, the rest of the patient referral, both pre-procedure and then our post-op care and patient follow-up and changes we've had to institute with that as well.
I don't see any other messages coming through the chat, correct? Needs to be.
I don't see any yet.
Nope, not yet.
Yeah, I don't see any right now. Yep.
Okay, perfect. So moving on to the patient referral initial evaluation. So as all of us, many of us had to do is once there was suspension or reduction of procedures, not knowing when they might restart and how we can restart, immediately, you go through kind of a program revamp of, we got to look at our patients and we got to kind of put them in line of who should get it first. And it's a terrible feeling to try and put them in order of who should get it first. But what we did was we developed a way to classify them. And I think this ended up becoming kind of a universal strategy, but we classified them through an A, B, C, and D category. And we even use that from consult as well as procedure. So A would be your most critical, D would be, anywhere from moderate AS to, certainly asymptomatic, can wait even for a consult, or do a virtual video consult to kind of get things established so that they know what to be aware of. So in the beginning, it was only class A patients. So those would be the inpatient, urgent, emergent, or those outside of the hospital who had a hospitalization outside of our current hospital, since we supply so many other counties. And really those having critical AS in the setting of a low EF, the syncope or class 4 heart failure. Just class A alone at one point was enough, and we were busy enough with that. Luckily though, starting in June, we were able to increase to class B and C. So that would then go into, you know, your typical NYHA class 4 severe, and then your class 2 severe AS patients. If they weren't class A in the beginning, we would do a virtual consult. Again, like I said, just to ensure that maybe their symptoms aren't worse than what the notes we're reading from an outside facility are, and ensure that they have the education to know what to look for, when to call, to have our number, to try and prevent them from coming into the hospital in more of an urgent setting, especially when we maybe are low on beds. And then June to current, meaning about 2 weeks ago as current, we went to increasing clinic consults and even clinic visits. And currently they were all in clinic unless per patient request. We will see that changing. I have actually changed that within our clinic this last week in regards to certain follow-ups, and now we'll be kind of going into what should we do for consults as things develop for safety of our patients as well. And then as far as evaluation, we ended up moving everything in the beginning in that first few months from March to May or February to May into a 1-day workup. Used to pretty typical as a 2-day workup, unless they had, you know, high concerns for chronic kidney disease. Then we just kind of had to figure out what to do on how to split up the CTA and the angiogram. But a lot of that was based off of anybody at that time would go through that path. And then after May, we still kind of kept that for a handful of patients, as long as they didn't have chronic kidney disease, depending on what their symptoms were. And then we have patients that sometimes travel a distance of at least 2 hours one way. And so we would try and give them kind of a full day workup throughout that time frame. We, in the last couple of months, have transitioned mostly back to our 2-day workup, except for in very rare occasions. But we are now seeing that we're going to be going back to 1-day workups in the last couple of people I've scheduled. Some of the tough part with that, so you end up finding additional workup that needs to be done, whether you think after doing their CT or an additional echo, the angiogram, you know, maybe there's more to the story. We find that in clinic a lot, that maybe, you know, is it the AS? You know, do we have a rhythm issue? Do we have something else? Because we want to ensure that what we're doing as far as a procedure right now, especially, is what's needed right now for that patient when we're coming into the hospital and having a procedure. We had very different, we kind of had a 2-way dynamic. There was patients that absolutely loved coming in for 1 day, having family could come, well, for a while. But having everything done, leaving with an answer, we had some patients and families that absolutely love that. And then we had some that were just so overwhelmed by all the information and how fast things were moving that some became quite anxious. And so for those people, it was a bit tough. And then you're having, you know, what we're doing isn't simple, especially in a patient and a family. When you're talking about a heart valve replacement, this is complex discussion that also can be very difficult to thoroughly educate and go over through a phone with a family member or whoever their support system is, as visitors were restricted in the beginning and randomly throughout the last 8 months. So, you know, these complex discussions with multiple providers, trying to make these decisions for their loved one on what we should do, what can we do, also was a bit overwhelming. But our goal always is that they leave with a TAVR date and a plan. So at least they're leaving feeling comfortable that we already have the next step set up. Next slide. So the next topic of change, then we're going into after procedures done, what are we doing as far as an inpatient post-procedure care? So with nurse sedation and no art lines, this really streamlined a great process for us where, you know, patients could, when our CVTU that's attached to our, you know, CICU was turned into a COVID unit, we could transition them to a telemetry, because typically every telemetry, you know, standard unit probably cannot take art lines unless you kind of have a mid-level floor. And so then there we could have increased post-recovery bed availability, as this was our biggest issue, and we could utilize additional nursing staff or have our normal nursing staff from our CVTU unit go over there, but at least we had a recovery bed that we knew we could safely go to. With conscious sedation or no sedation, again, some of this is mimicking some of the current ideas from the beginning, but you know, you really don't need that ICU or PACU bed. And with the hemodynamic stability, with the lesser sedation, we saw elimination of a lot of IV drips that we would do for, you know, asymptomatic bradycardia or hypotension. And it was, you know, lo and behold, kind of a side effect of the sedation or the Precedex. We continue with next day discharge. If stable, I would say that continued to rise. And even started the discussion of same day discharge if that became a necessity. A discussion we personally haven't implemented that. We do have institutions within Minnesota who have done that. And then we have Grecke House, which is, you know, kind of like a place. There's a lot of places that they can stay for a family member or a patient, even if they had to stay over for their workup or prior to their procedure if they're traveling. And that certainly is a huge savior for some people, especially now that winter's hit with all of this. A lot of travel can be difficult for our patients too, in that elderly population as well. And then COVID change on our patient follow-up. So a lot of the follow-up, as again, probably a lot of people felt, was we were able to start virtual visits. There's a love-hate relationship, I think, for these, but they hold a good place of being able to communicate with family and patients and ensure their safety and be able to visually see them, talk to them without having to bring them in, especially when we had patients who, especially when they felt well, they weren't going to come in. If they felt well, why would they come into the clinic? So everything went to virtual on a rare occasion, unless we had to physically see them either at consults, but mostly in follow-up was quite rare through July. And then that changed, and we started bringing most people into clinic with their echoes and lab work again to follow registry guidelines. Blood work was more rare. Typically, our institution, we all have to do the 1 month and the 1 year registry mandate, but we usually seen our patients at 1 week as well. And so blood work was reduced to those that if we needed to, based on their kidney function, they had contrast, a medication change, that blood work was reduced to that, because there was actually some clinics that they couldn't even, if they lived an hour and a half away, some of those smaller clinics weren't even open. They would have to drive just to get blood work. And then they're again in a clinic setting that they're kind of scared to go to. And then everybody was allowed to do some changes with registry to still meet guidelines. And so we followed that recommendation to be able to not fall too far out of the guidelines in regards to timing of the echo, and then ensuring that they got re-entered into our recall system so that they weren't lost to follow-up or their echoes were never completed as time went on. So challenges, we talked about, and Dr. Dali talked about kind of the good per se that could come out of this. And I think there's good and there's also challenges. Challenges, really the limiting of visitors and visitor restrictions, which were necessary, were quite tough on our community, our families, our patients, and us as providers, as they, there's a lot of pushback. I'm sure everybody experienced that. There's a lot of pushback to have at least one person for every single patient, even if they were independent and 60 years old and could come in on their own any other day. But with that was a big patient provider dissatisfier. So based on communication, patient preparedness, so being ready for their procedure, not having that anxiety throughout their workup and the decisions that are made, that certainly hindered that a bit. And then of course, increasing anxiety at time of procedure. Eventually this changed to one visitor for workup and TAVR. That was somewhat of a, physician decision on who meets criteria. Our hospital did allow us to have those conversations and say who absolutely did need a person, at least one or only one person available. And so eventually we did change to that, and currently are still at a one patient visitor or a one person visitor per patient. Virtual visits, it's providers and the patient's families, it's challenging to gauge patients' clinical status. A lot of people that say they're doing fine, and then you have their nurse, home care nurse call you and say they're up 5 pounds and they've been short of breath for the last week. So without being even video visits, it can get really tough to clinically understand their current status and try and continue to prevent them to stay out of the hospital. So that was a bit of a challenge. And then patient preferences could be different. Again, going back, a lot of people, we had like the one-day workup and a quick discharge. They weren't worried. They felt good. They wanted to get out of here. They wanted to get home. And for others, this was quite overwhelming. It took a lot of sit down with family and patient to calm that discussion and be okay and know that we had their best interest for them. And then valve conference was one thing. We have a lot of people that come to our valve conference. So of course we couldn't congregate in big groups. And so this was canceled. And then partway through the summer, we started doing a small group with the WebEx, and currently now canceled this again for right now. So with the second surge. What challenges will we keep post-COVID? So one-day workup, I think, will still stay. This will probably become still a rare occurrence, those for urgent workups, traveling a far distance, because we always have those patients despite COVID. So I think that is here to stay, and we've proven to ourselves and that we can do that safely, and that, certain patients do very well with that, and some maybe not. Nurse sedation is definitely here to stay. Cath lab TAVR is only increasing and will stay at an increased rate because our outcomes have been very good despite all of this. No art line. That is now a standard that we will not do art lines on our TAVRs unless they have general anesthesia. And this has all been in discussion with stakeholders. This is with discussion with the anesthesiologist. This isn't just us making a firm decision and this is what's going to happen. This is still talking as a team. But understanding what's needed and that we can safely still provide good patient care post-procedure without these things. As we see an increase in our inpatient urgent cases, our inpatient valve clinic staff are quite busy. That service was very busy for the first 6 months, and we are appropriately staffed for that. And we have an APP that's constantly seeing people in hospital Monday through Friday, and then virtual visits to some capacity, I think, are here to stay. That's it.
Well, thank you very much. I'd just like to mention that Dr. Iyer had an emergency, so he had to go take care of that. But I appreciate your presentations. I'm just going to look and see if there's any more questions. We still have quite a few people watching. If you have questions, please, I encourage you to chat them in. We still have the panelists. You answered my questions as you were going through, Sarah, because I was thinking about what changes, would you keep? Did you have the one-day workup on there? I'm sorry, I missed that.
Yeah,
the
plan is to continue that, but I think it will probably be a bit more of a rare instance, because once we could switch back to two-day workup, we did somewhat quickly on most occasions, and it's really just because of how our workup and our program is set up, how our APPs and physicians are utilized, how we have multiple areas that they have to go to. Our physicians aren't always in the hospital setting, since we have so many communities and counties we supply cardiology care to. Everybody has to kind of work with what's best for their program, and so at that time we decided to kind of go back to 2-day, but now we're going back to more the 1-day at the current situation.
And you think going forward it will depend on the patient?
Yeah, a lot of it's going to depend on if they're on a chronic kidney disease patient. I think we're going to be looking at more of is it a distance issue? How urgent are they? And we can better classify that, because we've lived it for how many months, and I think we can better understand who those patients are and who can handle it. Anxiety, complexity-wise, support system. We can get a lot of that over the phone and kind of discuss with the patient our options and what they might want to do.
A lot of discussion with the patient, it sounds like.
Yeah.
A lot of tailoring.
Yeah.
We do have a question in the comments. Brittany asked, for patients referred but denied procedure or surgery, do you refer them to outpatient palliative care? I think that's a very good question. I think oftentimes that's really a case-by-case basis that I've seen. I'll let Sarah answer that too. What are your thoughts?
I think throughout that process, we didn't have a lot of people deny them if we said, I don't think it's safe to. I think we do live in and I think, Dolly, we've talked about this a lot, like we do live in a state that, you know, when the physician kind of recommends something, they really, you know, say, all right, doc, you know, it's that kind of trust community. But we've had a couple that deferred it, but we felt comfortable that they had our number. We could do a virtual call. If things got worse, they knew that, you know, their outcome might not be as good, or we might not have an option for them then, or it might be too late, kind of a thing. So I guess to summarize, we really didn't have any patients like that we sent to palliative care. There were obviously some that we did for normal reasons, whether it was COVID or not, or deferring a procedure. But if it was just from deferring because of COVID and worried to be in here, I hadn't sent anybody to palliative care.
Yeah, I would say the most common thing we see for palliative care is sometimes on the inpatients who they'll contact the valve service to see if we can help. And, you know, it'll just be the patient's just not appropriate or just too ill or unlikely to recover, or oftentimes have multiple comorbidities. And although they ask us to see them for the AS is the least of the clinical picture. I would say those are the most common ones that, you know, really get referred to palliative care. We tend not to ever, you know, we have a pretty low refusal rate for anatomic reasons with our alternative access program and just a lot of some of the other things we do. Anatomically, we can usually find a way to do TAVR if a patient's a candidate for it or appropriate for it.
Yeah, and I think the only other time I can remember was somebody who wasn't within our valve clinic, and they ended up coming in too late because they made their decision not to come in, and they may not have been feeling well, wasn't aware that they had aortic stenosis. We did have a couple of those that they just came in too late and they were too sick, and so palliative care we got them involved. Impact your program.
We have another question there. Go. I'll just repeat it so people listening, if they don't see it. In regards to quality outcomes, have you seen COVID impact your program? So far, I would say we haven't. Our outcomes have been right along. We haven't had, as I mentioned before, we had 2 patients awaiting TAVR who died of COVID. We have not had any TAVR patients subsequently get COVID and have any complications from that. But we haven't seen any clinical outcomes or changes with any of the things we've implemented because of COVID.
Right. I haven't seen increase. Whenever somebody comes in post TAVR, we'll get a courtesy if it's within a short period of time. I really haven't seen a lot of people go through the ER or get admitted post procedure, even though they're a quick turnaround. They're here for 24 hours. A lot of that has to do with good nursing care in that first 4 hours, getting them active and getting them feeling comfortable, and ensuring that they have your number to call to prevent that ER visit.
There's another question there. With all these adjustments and changes, how have your economics and quality changed? I think that kind of marries with the previous question. Really, I haven't seen quality change in terms of our outcome. Economics, I can let Sarah answer, as we recently did an economic review looking at this, and maybe you want to comment on the results of that, Sarah.
Yeah, so I guess from an economic standpoint, we always focus on patient population that you're doing TAVR on. So were they outpatient, were they inpatient, were they heart failure, did you get your, capture your acuity of the patient? There's a lot that goes into that. I don't know, Phil, unless you have kind of some input on that, a direct change in economics, I don't think so. I think if you were to consider next day discharge, I think that'd be a big question that you'd have to answer before you start doing that.
Same day discharge.
What? Or same day discharge?
Same day, yeah.
Yeah, sorry. Same day discharge, not next day discharge, same day. But I think that's gonna be your biggest change that could affect your economics in this scenario. Bill?
I think if you look back to kind of where it started to where it's migrated to, the elimination of, not the total elimination, but the primary elimination of doing procedures in the OR and moving those to the cath lab, the elimination of anesthesia, the elimination of a PACU bed, not placing these patients in CICU, going directly to our cardiovascular thoracic unit, reducing the length of stay. and the throughput with these patients, what we ultimately done is significantly reduced cost. You know, the reimbursement for these procedures is set depending on which DRG they've fallen into. To Sarah and Dr. Dolly and the providers' credit, we have taken on clinical documentation initiatives, so we do get an MCC capture rate that's probably better than it was a year ago or even 2 years ago. So really between reducing costs, capturing MCC capture rate, the economics between today and what they were back when the OR and anesthesia were involved are significant.
Yeah, definitely cost reduction, yeah.
What kind of contribution margin changes are you seeing, Phil, compared to 2 years ago to now?
So are you looking for like a dollar number or
you know, a percentage improvement, or has it remained the same? Because the DRG reimbursements have pretty much stayed stable, a little bit higher, maybe not a huge change. So if you're cutting costs, let's say as a percentage of the total cost, what would we say, you know, because, you know, early days of TAVR, obviously everybody told us we lost money, but I think most of us believe that TAVR does make money for the hospitals now if your contribution margins are positive or nearly positive.
I would say we can safely say that the contribution margin between previous OR anesthesia supported TAVR to what occurs today is probably about a $5,000 delta.
Yeah, I was gonna say, yeah, probably around that. And we've always had a positive outcome with our TAVRs. You know, we've never been, in Minnesota, I know some states are different where, you know, what you get back, it seems like you're breaking even or you're losing, but we had always been able to be above that bar, but it only got better. I think by minimum, and this was pre-COVID though, but just these changes that we started implementing, and now we've successfully done them for the majority of all of our patients. I think the majority of cases at minimum were kind of a $1,000 to $3,000 gain per case, and I would say on average, you know, we can even get up to higher than that. And that was still though using anesthesia and some of those things. So eliminating those entities and all of that, transferring and then doing more cases because the throughput's higher is only going to accelerate that economic improvement.
I think Vijay, you might be on mute.
Yeah, there are two questions in chat. I don't know if you guys already took them on. One was, have we seen an increase in readmission rates with conduction abnormalities because of same-day discharge or fast-track discharges?
So we currently haven't done.
Go ahead, sir.
Okay, sorry. we haven't done same-day discharges yet, but next day discharge, I'm going to say no. But that was also pretty standard for a lot of what we've done, and we have we have a protocol that we've used for now probably about 1.5 years since we started Benchmark, where, you know, if there's something that's of concern, we do watch those patients maybe another day or put on an active Holter that can come right back to us if they have an electrical abnormality that's of high concern, changing beta blockers, things of that sort. And then those are the people that, you know, we stay in close contact with, EKG, soon after, et cetera. But we haven't seen an increase. Actually, we've seen a decrease over the last year and last month.
Yeah, I would say, you know, our pacer rate is generally in the single digits, usually about 6 to 8%, depending on the quarter. Really hasn't changed. And we've been, you know, about 90% next day discharge now for probably over a year, which is probably the biggest thing that helps our contribution margin increase as well. And just as Phil mentioned, on limiting the resources.
Are there any patients you would consider same-day discharge, especially if they have a pacemaker, a permanent pacemaker?
There are. I think where we run into a little bit different scenario compared to metropolitan cities is a large percentage of our patients come from pretty far away. And a lot of times they don't have resources in their town or even within an hour of them, should they have a vascular problem. That being said, you know, nowadays with, you know, best practices, everything else, the risk of a late vascular problem or late complication from TAVR is just extraordinarily low in our program. And I think that's when you can start having the discussion on same-day discharge, when your rates of that are low as well.
Phil, do you have any concerns about same-day discharges from the standpoint of reimbursement over time?
You know, if you look at what's happened with left atrial appendage closure, they have now approved codes for outpatient watchman or outpatient left atrial appendage closure. I think the concern would be is, if all of a sudden we start experiencing same-day discharge, will they start developing those outpatient codes for TAVR as well? And then all of a sudden you will see reimbursement probably go down.
Mm-hmm.
And I think one of the other questions we haven't addressed yet, kind of on the same lines of complications, was do you have a surgical team or room on call and available for bailouts? And should there be a complication in the case now that you've moved to the cath lab? And I think that's a great question. It's one that we've went back and forth on between the interventionalists on our team, the surgeons on our team, and the anesthesiologists. And it's something we've discussed quite a bit. Ultimately, about, when we made this transition, we went back and we looked at all our surgical bailouts. When have we had to bail out? And, in our program, in our history, we've never had to do a full open surgical bailout for a valve issue. The major catastrophes, we've seen, like everyone else, is, aortic root rupture, which generally they either stabilize or they're fatal. But the stabilization methods usually are putting on ECMO or pump support immediately, and pericardial drainage, which is generally done in the cath lab. And if they survive that, then you can talk about going to the OR for repair. But we decided as a team that it was really impossible for us to have a room and a team on standby for TAVR that's done in the cath lab, much like in the days where we used to have that for coronary PCI even. And we felt that, any of the immediate complications, we generally would be able to stabilize in the cath lab while we mobilize our surgical team and OR to figure out how we can do that. And again, in the history of our program, we've never had to do that to that extent. And so we felt it just seemed like a unnecessary use of resources, which we just don't have.
Do you as a team drill or prepare or run through scenarios like emergent pericardiocentesis, going on ECMO or rapid intubation to give your team a little bit of sense of comfort, or just more drilling to make sure that if it were to ever happen, everybody knows what to do and roles, etc.?
We do. I mean, unfortunately, in this business, I think just from a coronary standpoint, everything, we have a fair number of patients coming in with shock, cardiac arrest. We're a pretty big STEMI program. So, drilling, I think having drills is helpful, but I think real life experience with crashing patients, they might not be structural patients, but, our cath lab team, as you guys know, as I'm sure yours is as well, when we have all these unpredictable STEMI patients coming in that need, emergent support, ECMO, Impella, intubation, pericardiocentesis, 10 pacers. I find that we're actually more efficient and prepared for that in the cath lab than we actually were in the OR. We had a different team in our OR who's good, great for, the management that they had, but they didn't have the same experience, say our STEMI cath lab does with, rapidly changing patients in an uncontrolled situation, at a moment's notice.
Thank you, Tom. Do we have any other questions from the participants? Are there any other points you guys want to make, Sarah, Phil, or Tom?
No, I don't think so. I think, playing on that point, again, that still comes down to some discussion of how would you react in that type of scenario, because you want to be ready for even the less than 1% chance of something like catastrophic happening where you do have to change. And we did that. It was that conversation, and what would we do when we have a plan that's known hospital-wide and all those departments of how we would do it, and everybody was in agreement with it. And, when you look at a rate of less than 1% chance of something like that happening, it's tough to just say, you have to be sitting on standby just for this versus it's one of the teams in the OR that's maybe floating, that is your resource, because that's a typical routine that you have a resource team of, a person, like a nurse, and then a perfusionist, etc. And so really it's utilizing those people.
As we go, into the Thanksgiving holiday, and as we see across the Midwest, East Coast, everywhere, numbers going back up. For you guys, as you look forward, what are you looking to do with your program for the next 6, 8, 10, 12 weeks so that you can maintain your throughput while maintaining safety? I mean, are there any lessons we learned from our previous experiences that we need to change, or we feel like we can change at this time? So
I think maybe each one of us can touch on that as we close. I think from our standpoint, I think the biggest thing is being open to change and being able to react quickly. And I think, as I mentioned earlier, COVID is the great equalizer that has taught us that even when we think we have great, the best laid plans, they can change overnight. And we're seeing that on a daily basis right now in Minnesota. Unfortunately, as many places are, especially up here in the colder climates, that people move indoors and families. We just have to be able to change. And I think the biggest aspect for that is really a multidisciplinary action that's brought together not only by hospital administration, our valve coordinators, our nurses, our CICU, and our surgeons, our interventionalists, and having everyone at the table and having people help coordinate that change is just crucial to be able to react to this, because oftentimes what one group might think is not a big deal for them to change affects someone else, or there might not be a bed or things like that. So I just have to credit Phil and Sarah for really being able to help manage that and bring everyone together. And I think that's the most critical piece of this COVID era, which we always work together as a team before, but I think it's even more crucial now to be able to do that.
Yeah, unfortunately, this the second surge is already proving to be much worse than the first. So I think we've learned tactics to be able to adapt, and we've already made some different changes, like as far as our procedures, 1 a day. We prepare patients that if we have a bed and things are still okay within the hospital and community, we may call you on a whim in 24 hours and they're ready to, come in. But I think we're still going to have things that we're going to continue to learn, just because this is proving to be more difficult than the last one. Just on biggest thing is bed availability. So I think we'll still have things that we'll learn, but we adapted quite well and got a lot of patients still through safely without any major big complications or concerns, or, a lot of people leaving the hospital with COVID and concerns of that sort. So we'll kind of have to see what else we adapt.
Yeah, I would say, from an organization perspective, I think organizations need to make a decision whether they're going to be COVID hospitals, COVID and heart hospitals, or some mix of that. I think one of the things that was learned from the first surge is that there was a lot of heart patients that suffered by delaying their care, which was evident by some of the slides that we presented today. When you look at our particular hospital that sits in central Minnesota and the geography that we support, we cannot become just a COVID hospital. We have to figure out a way to balance that with managing the cardiac patient population in this region. And I can tell you that whether that's myself or Dr. Dolly or Sarah or anyone else that's involved in this heart program, we're going to fight that battle to the end. We have to keep the program live. I can tell you that I was on an executive summit last Thursday night, which was a representative of executives across the United States, and everybody shares that same sentiment. And a lot of those that have already experienced the second surge didn't make that commitment going into the second surge, that they had to keep operational so we could continue to treat this patient population.
Before we end, let me ask you this one last question. And I've thought about this for the last couple of months. The way we've done TAVR during COVID, we've learned we can be even more minimalistic than we ever were. Is there ever a reason to think about going back to the old way?
That's a tough question. I don't think so from a procedural standpoint. I thought Sarah touched on some good points, that sometimes it can be too fast for patients and families. And And I think that's a very good point. You know, the TAVR patients, while, you know, they're not necessarily elective or non-urgent, as we talked about, but they're not necessarily STEMIs either, that we need to go full force without even talking to family and the patient, just kind of getting things done. So I would say from a procedural standpoint, I see a lot of these changes permanently, but from the speed of the workup, as Sarah mentioned, it is too fast, I think, for some patients and families, and I think we'll see that slow down in the future post-COVID.
Yeah, I would echo that. I think the procedural stuff is to stay, because it's a lot of stuff that we wanted to be implementing anyways, or we're about to. And then you realize that you can, and you can do it safely in a setting that we just kind of had to. And even in this kind of, you know, I don't know if I'd even call it controlled chaos, just kind of some chaos. We still did it well, and we did it with patient safety still. So I think a lot of that's to stay, and then there's going to be things that revert back to the usual from pre and post procedure as far as workup and follow-up.
I think that these guys have made this procedure look so simple that sometimes people forget just how complex it is and what can go wrong. And I think because of that, organizationally, sometimes there's a push, you know, to keep advancing. And we do have to sit back and think about, you know, we're putting a valve inside of, we're crushing somebody's valve and replacing it with, you know, mechanical valve. It's a different, we can't lose the appreciation for how wonderful and how complex this is.
Mm-hmm.
Well, Tom, Phil, and Sarah, thank you so much for taking your time and participating on behalf of Edwards and the Jacobs Institute. Really appreciate your time. I'll give all the participants.
I think you're muted.
Oh, yeah. It just went to mute. There you go.
Are we good?
Yeah.
You guys,
Yep.
all right. I guess if nobody was on chat, if you have no further questions, thank you all. I really appreciate your time. And Tom, I hope your axe throwing bar is opening.
Thank you. Appreciate that.
Thank you all, folks. Be safe and wish you a very happy holiday season. Thank you.
Thanks,
Good luck, everyone. Thanks, everyone,
Thanks,
for joining.
everyone.
Yeah, thank you.